Okay, great. Thanks so much for having me. I do not have any great pictures to show you like in the plastic surgery talk, but I do have some beautiful survival curves, so hopefully that'll make up for it. My name is Olga Cantor. I'm a breast surgeon at Brigham and Women's in Dana-Farber, and I'll be talking to you about updates in surgical management of the axilla. And specifically, I'm going to try to highlight some of the recently presented and published work that's kind of come out over this past year. I have no disclosures. So today I'm going to be discussing a few different topics. They are kind of all unrelated, so maybe we'll pause after each one in case there's questions. And so first, I'm going to talk about some strategies for optimizing axillary staging in the upfront surgery setting. First, discussing omission of axillary lymph node dissection in patients that have positive sentinel lymph nodes after mastectomy. Next, talking about optimizing the use of preoperative imaging with axillary ultrasound to select patients for neoadjuvant therapies. Then talking about the omission of sentinel lymph node biopsy completely in early stage breast cancer, and then touching on some axillary management considerations after neoadjuvant chemotherapy, specifically the management of residual nodal disease. So first, I just want to take a moment to talk about why, as surgeons, we kind of dwell on this issue. We're kind of seem like we're obsessed with de-escalation trials and trying to do less and less in the axilla. But we know that minimizing morbidity when oncologically safe really should be a priority. And any surgery in the axilla, and especially axillary lymph node dissection, is associated with morbidity. So there's been some nice work out of our group looking at arm symptoms after breast cancer treatment. This study shown here is a study of young women with breast cancer, age 40 and younger, that underwent surgical treatment from 2006 to 2016. Almost 900 patients were surveyed 1 year after their surgical diagnosis. And compared to those patients that had sentinel lymph node biopsy alone, arm swelling at 1 year self-reported was significantly higher in patients undergoing axillary lymph node dissection, at 17% in those patients that had mastectomy without radiation, and at 25% in both those patients that had breast conserving therapy and mastectomy with radiation, compared to only 4 to 13% in the sentinel lymph node group. Additionally, on adjusted multivariable models, axillary lymph node dissection was the only predictor of increased arm swelling at 1 year, while overweight BMI, lymph node dissection, and post-mastectomy radiation were all associated with decreased range of motion at 1 year. Some additional work was recently published, again, out of our group, now looking at arm symptoms 10 years after breast cancer treatment. These were women of all ages, surveyed 10 years after diagnosis. 882 women were included. And you can see that even in the no axillary surgery group, there were some symptoms related probably to radiation treatment and other treatments that they received, with about 20% of patients reporting any symptoms 10 years out. That, of course, was higher in those patients with axillary surgery, 31% in the sentinel lymph node biopsy group, 47% in the axillary lymph node dissection group. And severe symptoms were, of course, highest in the AL&D group at 13% compared to only 5 to 8% in the other groups. And in those patients that had AL&D, 40% reported pain, 22% range of motion limitation, and 20% swelling. And again, this is 10 years out from breast cancer treatment. And so moving on to kind of our first topic, which is going to be omission of axillary lymph node dissection in positive sentinel lymph nodes after mastectomy. So as I'm sure this group knows, several clinical trials have shown that omission of axillary lymph node dissection is safe in patients with clinically node-negative breast cancer, found to have 1 to 2 positive sentinel lymph nodes. Axillary recurrence rates are consistently less than 2% between study arms at 10 years out from treatment, and there are certainly no differences in overall survival. 2 of these trials, the IBCSG 1301 trial focusing on micrometastases and the AMAROS trial, which also included macrometastases, included mastectomy patients. However, only about 9 to 17% of this population had mastectomy, and so optimal axillary management in this group of patients that undergo mastectomy does remain an area of controversy, at least in the surgical world. Adding some additional data to this question was the SEMINAC trial, which was recently presented at San Antonio Breast Conference in December. CENIMAC was a European trial of omission of axillary lymph node dissection. It was focused on overcoming some of the shortcomings and criticisms of the Z11 and AMAROS trials, specifically power, patient selection, and documentation of radiation fields. 2,766 patients were enrolled. They allowed patients with clinical T1 to 3 node-negative breast cancer, and patients with positive sentinel lymph nodes were then randomized to either undergo sentinel lymph node biopsy alone or to have axillary dissection. So a similar trial to Z11 and AMAROS in general. One difference was that preoperative axillary ultrasound was mandatory on this trial, which was not mandatory on either Z11 or AMAROS. Patients with up to 2 sentinel lymph node macromets were enrolled. This study did include mastectomy patients, and they also did enroll male patients. And so it's the first study to enroll male patients in the setting. Regional nodal irradiation use was not specified or mandated by the trial, but it was extremely common, and about 90% of patients across both arms received regional nodal irradiation, really suggesting this is more of an AMAROS population than a Z11 population. And this report was of their secondary endpoint, which was recurrence-free survival. So the study characteristics are shown on the left. In general, the median age was 61. There were 10 male patients enrolled, which was only 0.4% of the population, but they were included. T3 cancers represented 6% of the population, and they were not included in Z11 or AMAROS, so this kind of expands eligibility. Mastectomy was very well represented at 36% of the population. Lobular cancers were well represented at 20% of the population. Extracapsular extension was present in about 1/3 of the population. And most of these patients were hormone receptor positive, HER2 negative, 87%. And most patients, 85%, only had 1 sentinel lymph node macrometastases. So the median number of nodes removed was 2 in the sentinel lymph node biopsy arm, 15 in the axillary lymph node dissection arm, and in the ALND arm, the rate of additional non-sentinel lymph node disease was 35%, and it was 31% in those patients that only had 1 positive sentinel lymph node, and it was 51% in those patients that had 2 positive sentinel lymph nodes. Recurrence-free survival is shown in the curve on the left. As you can see, the 2 study arms clearly overlap without any difference between the recurrence-free survival in these 2 groups. The estimated 5-year recurrence-free survival was 89% in the standard of care or axillary lymph node dissection arm, and it was 89.7% in the intervention or sentinel lymph node biopsy arm. And this was a non-inferiority study, and the non-inferiority p-value was met. Shown here are some of the subgroup analyses of age, stage, the number of macrometastases, the tumor subtype, surgery, extracapsular extension, and clearly all of these hazards ratios are crossing 1, and there was not any subgroup that favored axillary lymph node dissection in this study. The only hazard ratio that actually doesn't cross 1 is in estrogen receptor positive, HER2 positive breast cancer, which actually favored the sentinel lymph node biopsy alone arm, but probably just reflects a power issue. So the CENIMAC trial reinforces that omission of axillary lymph node dissection is safe in lieu of axillary radiation for mastectomy patients with positive sentinel lymph nodes. And although both AMAROS and CENIMAC suggest that really axillary lymph node dissection or axillary radiation or axillary lymph node dissection are kind of equal in terms of survival and recurrence, they certainly both have pros and cons. So axillary radiation, of course, is associated with significant side effects. It has implications for reconstruction, as we saw in the previous talk, with higher rates of complications and reconstructive failure, and there's increased treatment time and expense for patients. While axillary lymph node dissection is associated with increased arm morbidity, there are higher rates of lymphedema, as I showed you, and decreased quality of life on patient-reported outcome measures. And I think with axillary lymph node dissection, this might still be the problem with kind of going straight to ALND in these patients is that post-mastectomy radiation with or without axillary fields may still be recommended depending on the final nodal burden or other characteristics on final pathology. And so I mentioned earlier that optimal axillary management after mastectomy really remains an area of controversy, and that's really reflected by this study, which shows significant variation in practice patterns amongst breast surgeons on this topic. So this was a study of the American Society of Breast Surgeons, 680 surgeons replied to this survey. The question was about the management of clinically node-negative patients found to have positive sentinel lymph nodes. 52% of surgeons reported that they are routinely doing intraoperative pathology assessment of the sentinel lymph nodes. And if those sentinel lymph nodes are positive during surgery, 78% of surgeons are going ahead and immediately performing the axillary lymph node dissection to avoid taking patients back to the operating room. However, this approach of acting on that intraoperative finding really doesn't allow for the multidisciplinary input from radiation oncology to decide whether or not axillary radiation could be an alternative to ALND in this setting. So at Dana-Farber and Brigham Cancer Center, we initiated a multidisciplinary protocol with input from our radiation colleagues after publication of the AMAROS trial. This went live in 2016. Our plan was to omit intraoperative pathology assessment in these clinically node-negative patients undergoing mastectomy upfront, that if found to have positive sentinel lymph nodes, they would have other considerations for post-mastectomy radiation. And so in the turquoise here on this chart, you can see in a historical cohort of patients from 2005 to 2015 prior to this protocol, most patients that had one or two positive sentinel lymph nodes undergoing mastectomy were getting both axillary lymph node dissection and axillary radiation, and only about 6% were having axillary radiation alone. Following initiation of this protocol in the 2 years following it, when the protocol was followed, we were able to decrease that rate down to 9% of patients meeting this kind of AMAROS criteria that were getting both axillary lymph node dissection and axillary radiation. And most of those patients are instead now getting axillary radiation at 63%. However, in those patients that the protocol wasn't followed, those patients continue to have high rates of both axillary lymph node dissection and axillary radiation. In our experience, there was only one axillary recurrence at about 3 years of follow-up. This actually occurred in the observation group in an older patient, and following the protocol was found to decrease rates of axillary lymph node dissection by about 16%. It decreased rates of both axillary lymph node dissection and post-mastectomy radiation by 32%, and only 16% of patients ended up returning to the operating room for an axillary lymph node dissection, and 46% of those were actually spared post-mastectomy radiation. So again, suggesting that that multidisciplinary input is really key when thinking about this approach. Our group was also interested in examining kind of more national practice patterns of utilization of intraoperative pathology. And we did this using the National Cancer Database from 2018 to 2019, looking at, again, AMAROS eligible patients found to have 1 to 2 positive sentinel lymph nodes undergoing upfront mastectomy. About 63% of patients in the NCDB were having intraoperative pathology either not performed or not acted on, and about 37% were having intraoperative pathology performed and acted on. And you can see in the group that did not have intraoperative pathology, the rates of axillary lymph node dissection and axillary radiation together are quite low, only about 5%. While in those patients that had intraoperative pathology performed, everyone got an axillary lymph node dissection, and about 41% had both axillary dissection and axillary radiation. And so not doing intraoperative pathology, or at least not acting on that intraoperative pathology assessment, decreased rates of axillary lymph node dissection by about 52% in this national cohort, and it decreased rates of both ALND and axillary radiation by 36%. Only 12% of patients in this cohort returned to the operating room for an axillary lymph node dissection. And again, 58% of those were spared axillary radiation. So even in those patients that have to return to the operating room, we are kind of still able to tailor their treatment so they're not getting both treatments. So I'm going to, just to summarize, omission of axillary lymph node dissection in lieu of axillary radiation is safe in clinical T1 to 2 node negative patients with positive sentinel lymph nodes undergoing upfront surgery with mastectomy. And I think that this should be widespreadly This should hopefully become widespread practice. I think the CENIMAC trial suggests that maybe even we could consider T3 tumors, at least on the smaller side, into that category, where all those kind of still remain an area of controversy, at least at our institution. Routine intraoperative pathology assessment of the sentinel lymph nodes and clinically node-negative front mastectomy patients certainly seems to lead to overtreatment of the axilla, specifically in the use of both lymph node dissection and axillary radiation. And I just like to point out that multidisciplinary discussion and protocols is so important in trying to develop and optimize these protocols to minimize morbidity. So I'm going to briefly pause because all of the other topics are unrelated, just in case there's any questions on this specific topic. All right, then I will move on. So switching gears a bit to optimizing the use of axillary ultrasound to select patients for neoadjuvant therapies. So as this group knows, in hormone receptor positive and triple negative breast cancer, neoadjuvant therapies can improve survival by selecting patients with residual disease for additional therapies. And this has been shown in several trials, including the Keynote 522 and CREATE-X trials in triple negative breast cancer and the Catherine trial in HER2 positive breast cancer. And so it is therefore important to identify patients with node positive disease that may not otherwise meet criteria for neoadjuvant treatments, and I think specifically patients with T1 tumors clinically. Axillary ultrasound can potentially be a useful tool in identifying non-palpable nodal disease. Our group was interested in examining the rates of nodal positivity amongst patients with clinical T1 to 2 node negative triple negative breast cancer using a combination of our institutional data and national cohort from the National Cancer Database, with the T1C group really being of most interest, as the management of this group with upfront surgery versus neoadjuvant chemotherapy is not always clear and can go either way. So in patients with clinical T1A or B tumors, the pathologic node positivity rate was about 9% in our institutional cohort and 5% in the national cohort. In clinical T1C tumors, the pathologic node positive rate was 15% in our institutional cohort and 11% in the national cohort. And then clinical T2 tumors, it was about 20% in both cohorts. I think even more importantly, in a subset of patients that were clinical T1C at our institution that did not have any palpable nodal disease, but underwent routine axillary ultrasound on an unrelated protocol, about 7.5% were ultimately found to be node positive. And so probably a good amount of these patients with pathologically node positive disease could be selected for, we could hopefully find that disease pre-op and then select them for kind of the appropriate neoadjuvant treatments, when a lot of these patients would probably undergo upfront surgery if we didn't identify that lymph node disease. A similar study kind of examined the same questions in HER2 positive breast cancer using 2 institutional cohorts, again, one from our institution and one from an institution in Spain. Amongst T1A and B tumors, about 9 to 10% were pathologically node positive in these HER2 positive patients. In clinical T1C patients, about 25 to 29% were pathologically node positive. And amongst clinical T2 tumors, about 28 to 36% were clinically node positive, pathologically node positive. So again, just suggesting that axillary ultrasound, if implemented routinely, would be helpful to hopefully identify a cohort of these patients that would then be more eligible for a neoadjuvant approach. So axillary ultrasound in triple negative or HER2 positive disease certainly may help select patients with subclinical nodal disease for appropriate chemotherapy regimens in those patients with small tumors that might otherwise go to upfront surgery. And routine axillary ultrasound in at least the T1C population of triple negative and HER2 positive patients should be considered. And this is something we're now routinely doing at our institution. I know at other institutions, pre-op ultrasound is done on everyone, so maybe not as important, but something that has been a practice change over the past few years for us. Any questions on this topic?
Are you doing this as part of their diagnostic?
Great question. So we're not doing it routinely because we are not routinely doing it for hormone receptor positive, HER2 negative patients, because those in that group, the surgeons feel strongly that we don't want to over-select those patients with positive nodal disease. And so this is something that we're really doing at their cancer consult, so as a separate subsequent imaging study. All right, so next, moving on to something that's been a bit of a hot topic in the surgical world this year, omission of sentinel lymph node biopsy completely in early stage breast cancer. So the idea of omission of axillary staging is certainly not a new one and has been somewhat widely implemented in older patients. And I think this really started after a publication of the long-term results of the CLGB 9343 study, which was a study of clinical T1 estrogen receptor positive breast cancer in women age 70 and older. All patients received lumpectomy and tamoxifen, and women were randomized to radiation or not. Now, this was not an axillary management trial. However, this also predated sentinel lymph node biopsy, so axillary staging at that time was with lymph node dissection. And although lymph node dissection was allowed, it was not encouraged on the study. Further, no mandated axillary imaging was included, so this was just palpation of the clinical nodal determination. And about 2/3 of patients in the study had no axillary staging. And so of the 244 patients that had lymph node dissection, there were no axillary recurrences. In the 195 patients that did not have axillary staging but went on to get radiation, there were no axillary recurrences. And in the 200 patients that had axillary staging and did not have radiation, there were 6 axillary recurrences, although of course no differences in overall survival. And so I think this is probably the most interesting group, this group that did not have axillary staging but did have radiation. And there's been significant interest in looking at this in a broader population of patients that are younger than 70. And so there are several ongoing clinical trials looking at omission of sentinel lymph node biopsy or axillary staging completely in early stage breast cancer in patients that are undergoing breast conserving therapy. So everyone's getting a lumpectomy followed by radiation. The SOUND trial, I'm going to show you some data from, and that's recently accrued. SOUND included just T1 patients. And then the other 4 trials listed here in SEMA, BOG 21308, SOPET, and Nautilus are all including both clinical T1 and T2 patients. All of these trials are requiring negative preoperative axillary imaging with either ultrasound or MRI or PET scan in the SOPET trial. And most of them are randomized studies, although SOPET is an observational study. So the SOUND trial was presented and published in terms of its first results this year. And SOUND included T1 tumors less than 2 centimeters. All patients were clinically node negative by both palpation and a negative axillary ultrasound. All patients underwent breast conserving therapy, and patients were randomized to sentinel lymph node biopsy versus observation. About 1,460 patients were enrolled. Just of note, patients with one suspicious lymph node that was biopsy proven negative were also allowed on this trial and were considered ultimately as axillary node negative. So clearly the groups are well balanced. The median age of patients in this trial, all ages were allowed, but the median age was about 60. About 20 to 22% were premenopausal patients. The median T size was 1.1 centimeters. Most patients had ductal cancers, about 78%. Most patients were not grade 3, only about 18% were grade 3. And most patients were estrogen receptor positive, progesterone receptor positive, and HER2 negative. In the sentinel lymph node biopsy arm, 85% of patients were also pathologically node negative. 11.7% of patients only had 1 positive sentinel lymph node, and 2% had 2 or more positive sentinel lymph nodes. So clearly this represents a group that has a pretty low burden of disease. The primary outcome of this trial was 5-year distant disease-free survival, which is shown on the left. Clearly, these curves overlap, and there was no difference between the 2 study arms with a p-value of 0.67. Disease-free survival is also shown on the right, with again, no differences between study arms. So as we start thinking about how this can be implemented into clinical practice, I know this one probably gives the medical oncologists some palpitations. I know probably gives the radiation oncologists some palpitations too. I think the way that our group has started to think about this is that at least in the context of hormone receptor positive, HER2 negative breast cancer, where tumor biology is really driving treatment decisions and specifically genomic assays in postmenopausal women, omission of sentinel lymph node biopsy probably is reasonable in those groups. There's a small low axillary burden. The chemo decisions aren't necessarily going to be made if someone has 1 or 2 positive sentinel lymph nodes in that postmenopausal group with the low oncotype. And so I think that's probably the group where it's most reasonable to think about implementation. Obviously, this isn't really mainstream yet because this is all new data and still lots of additional randomized data to come. And I think as we think about how to implement this, multidisciplinary buy-in and input is absolutely critical because there's just so many different facets from the different teams involved in managing these patients.
Do you think your group will continue to not want to do
Exactly. So that would be a big change in our practice. So our group is thinking about how we are going to implement these sound results. And we have not finalized it yet, but we've had several discussions between the surgery, radiation oncology, and medical oncology groups. And what everyone feels comfortable with right now is maybe hormone receptor positive, HER2 negative patients between ages 60 and 70. And maybe instead of having routine sentinel lymph node biopsy, those patients are going to get routine preoperative axillary ultrasound. And if negative, that's probably the group we're going to think about omitting sentinel lymph node biopsy in. And then I think maybe as additional data comes out in bigger tumors and just more data overall and longer term data as well, maybe that's going to expand over time. But that's what, we start small and we work up from there. So maybe in a few years, I'll have some data and how that's going for you. Any other questions on sound or anything along these lines? All right, so lastly, I'd like to touch base on the management of residual nodal disease after neoadjuvant chemotherapy. So in clinically node-positive patients undergoing neoadjuvant chemotherapy, many patients will have a pathologic complete response in the nodes, and that allows us an opportunity to omit axillary lymph node dissection in these patients. Initially, when these kind of first trials showed that this approach was feasible and safe, there was significant focus on decreasing the false negative rate due to really the unknown significance of missing axillary disease after neoadjuvant therapy in these patients. However, now, a few years later, there's really a significant growing body of outcomes data, which has suggested that this is safe and really safe regardless of the axillary staging approach in patients that are pathologically node negative. So this chart outlines the evolving data on omission of axillary lymph node dissection in patients that are clinically node positive and pathologically node negative. This is broken up by different axillary staging techniques. The turquoise on the top represents patients staged with just sentinel lymph node biopsy alone. Some of these studies included dual tracer. Some of these studies required 3 or more positive nodes, but it was pretty mixed. The yellow represents a Dutch study of just removing the clipped node, in which case only 1 node was removed. And interestingly, none of those patients had radiation. And then the 3 studies at the bottom are looking at kind of the dual technique of both doing a sentinel lymph node biopsy and making sure the clipped node is removed. But I think overall, across all of these studies, which have follow-up ranging from 2 to 10 years, the rates of axillary recurrence are quite low and are really ranging from 0 to 3%. And we know that axillary recurrence is a pretty early event, usually occurring within the first 3 years. And so we do think this is kind of long enough follow-up in this setting. So in those patients that do have residual nodal disease, and that disease is either micro or macro metastases after neoadjuvant chemotherapy, studies have suggested that there's a pretty high nodal burden of additional positive lymph nodes. And so axillary lymph node dissection at the current time, I would say, remains standard of care. And so 3 trials have really looked at this. The Z11 Z1071 trial clumped micro and macro mets together. In patients that had positive sentinel lymph nodes, 60% had additional non-sentinel lymph node disease. And the SNF-NAC trial, 37% of patients with micromets and 64% of patients with macromets had additional non-sentinel lymph node disease. And in a large series from Memorial Sloan Kettering, 56% of patients with micromets and 62% of patients with macromets had additional nodal disease. And so that's obviously a much higher burden than we're seeing in the upfront surgery setting in clinically node negative patients. However, residual isolated tumor cells alone after neoadjuvant chemotherapy is fairly uncommon. And so the residual nodal burden and axillary management of these patients really isn't well defined, as they kind of straddle that boundary between node negative and node positive after chemo. And so this study was recently presented at this year's San Antonio Breast Symposium. It was the ICARO study. It was a large international retrospective consortium of patients that had ITCs after neoadjuvant chemotherapy. They enrolled patients with T1 to 4 and 0 to 3 non-metastatic breast cancer. Inflammatory breast cancer was excluded, but everyone else was allowed. All patients had some kind of axillary staging technique with either sentinel lymph node biopsy or targeted axillary dissection, and the detection of ITCs was either by H&E or IHC staining. They were able to accrue 583 of these cases with residual ITCs after neoadjuvant chemotherapy, 31% of which underwent ALND and 58% of which did not. Their median follow-up was 3.2 years. There were a few differences in the groups. The number of sentinel lymph nodes removed was a little bit higher in the no axillary dissection group at 3.5 compared to 2.8 in the axillary lymph node dissection group. However, the number of sentinel lymph nodes with ITCs was exactly the same at 1.2 in each group. ITCs detected on frozen section was higher in the axillary lymph node dissection group at 62% compared to 8% in the no axillary dissection group. And regional nodal irradiation was a little bit higher in the axillary lymph node dissection group at 82% compared to 75% in the no dissection group. In the 182 patients that did have an axillary lymph node dissection, only 30% had additional positive lymph nodes, and most of that additional positive lymph node disease was additional ITCs only. And so only 5% had macrometastases in the non-sentinel lymph nodes, and only 7% had micrometastases in the non-sentinel lymph nodes. Axillary recurrence, either combined with local and distant recurrence or as an isolated event, was no difference between the two groups. And in terms of isolated axillary recurrence, their estimated 5-year rates were 1% in the no ALND arm and 1.7% in the ALND arm with non-statistical p-value. So in terms of thinking about how to kind of put this into clinical practice, I think this is the largest study we're going to get on this ITC question. It's not really something that's randomizable in clinical trials. I think ALND is probably not necessary in these cases of residual ITCs alone, specifically because they seem to have a low burden of additional positive sentinel lymph node metastases. And so they're probably routinely dissecting these people is really unlikely to change systemic therapy decisions from a medical oncology point of view. I think this also raises the question, as before we thought that identifying every cell of residual disease was really important to decrease that false negative rate. And so we have been kind of incorporating routine IHC staining to try to identify that disease in the neoadjuvant setting. But is there still a role for that? Now suggesting that, first of all, the outcomes data really doesn't support that it is so important to kind of do everything we can to minimize that false negative rate. And maybe ITCs don't need to be dissected, so identifying those ITCs may not be quite as important. And then, of course, we continue to await the results of the Alliance 11202 trial to help guide the safety of omission of axillary lymph node dissection in lieu of radiation therapy in the setting of micro and macro metastases. All right, that's all I have. I'm happy to take any questions.
Practice with that actual ultrasound data. What setting are you using breast MRI?
Great question. So we are, even in the patients that get breast MRI, we're still asking them to get an axillary ultrasound just because our imaging group feels that, you know, there is some additional benefit that in terms of kind of identifying those lymph nodes, and MRI sometimes misses some of the axillary fields or it's just not clear. So we're kind of doing it regardless of whether or not the patient has an MRI.
We have any other questions?
Right, thanks.